Good morning and welcome. Thank you for joining us for today's training. Next slide, please. Today's training is an introduction to creating a trauma-informed culture in the post-acute and long-term care facility, part 1 of a 4-part series. Hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence. And it is my pleasure to introduce to you our presenter for today, Ms. Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered trauma-informed care, nonviolent communication, sustainable process improvement, and advanced care planning. Paige writes extensively on topics relevant to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, 2nd edition, due for publication in 2023. She is actively involved in the AMDA Education Committee, the Diversity, Equity, and Inclusion Work Group, and the Behavioral Health Advisory Council, as well as national work groups to improve trauma-informed care. In 2018, she was named the Gerontologist of the Year for the Arizona Geriatrics Society. And now I'll turn it over to Paige to begin today's presentation. Thank you, Paige.
Good morning. Thank you to Nikki and all the team at the Center of Excellence for Behavioral Health. It's my pleasure to be here and begin our series all over again. We're starting at part 1. So truly, this has been one of my really favorite topics to talk about. How do we bring about trauma-informed care culture in our post-acute and long-term care facilities? Really, we're going to focus today on key trauma-informed care terms and concepts, and then how they apply in the nursing home setting. When you think about trauma, when you hear that word, what comes to mind? You know, a lot of times we think about any number of events, and I could actually have multiple slides just on the potential sources of trauma, because they're endless. Whether it's verbal, emotional, sexual, physical, any kind of abuse or assault, neglect, poverty, unsheltered living, attachment injuries, bullying, shaming, discrimination. Of course, there's the generational trauma that we see with Holocaust survivors, slavery, genocide, victimization, that the family, the children, and even the grandchildren, that those things are carried through our genes, that they come through even though we didn't experience the event firsthand. So the point here is that the sources of trauma are extensive. It can be basically about anything, and it depends on a lot of factors. And then witnessing any of these events could also be experienced as traumatic. Some of you may be familiar with Dr. Gabor Mate. His newest book is The Myth of Normal, and several things stand out to me, but this one here really sets the stage for us, is that trauma pervades our culture, from personal functioning through social relationships, parenting, education, popular culture, economics, and even politics. In fact, someone without the marks of trauma would be an outlier in our society. It just amazed me, that word right there, without the marks of trauma would be an outlier in our society. That includes all of us on this call. And while we're focusing on residents and patients in our communities, I always encourage people to keep these principles in mind and how they relate to each of us. The definition that CMS uses is this one. Individual trauma results from an event, series of events, or set of circumstances experienced by an individual as physically or emotionally harmful, life-threatening. It may have lasting adverse effects, and then any number of these domains, including mental, physical, social, emotional, and spiritual well-being. I want to bring our attention to another definition of trauma, is the emotional and psychological trauma, which is the result of extraordinarily stressful events, shattering a sense of security, making us feel helpless in an otherwise dangerous world, involving a threat to life or safety, but really any situation that has a sense of feeling overwhelmed and isolated may result in trauma, even if there is no physical harm. That is really key as well. Even if there's no physical harm, the more frightened and helpless we feel, the more likely we are to experience being traumatized. So of course, as I read that slide, as I've done many, many times, it really brings to mind the impact of this pandemic, that even the physical safety danger may not be as prevalent as it was before. There is still very much emotional and psychological effects of what we've all been through. Dr. Peter Levine is another well-known researcher and trauma expert, and he says that trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of human suffering. Again, I'm going to point out that this is not just residents and patients. It's all of us and our families, all of us on this call. There's yet another definition I want to bring your attention to. It's medical trauma. These are psychological traumas resulting from diagnoses and or interventions. And I want to bring extreme tenderness to this topic because as healthcare professionals, all of us, no matter what discipline, experience, training, background we have, all of us that work in healthcare, we come to work every day with the intention to care and to heal and to give hope and recovery. So what's really difficult is carrying the knowledge that there are things that we do as staff that might be very medically appropriate and expected, but can also be experienced as traumatic by the person that we are caring for. So this is just when I think about all the things that we do in nursing homes, assisted livings, and then how we go about bringing care and tenderness, not just to the staff, to residents, but also to staff, because this is very difficult. It's like the moral injury component of trauma when we talk about this one. There are potential sources of medical trauma. Again, I always say these are partial lists. All of these things here, just receiving a new diagnosis, for example, cancer, interacting with the healthcare system. We all know how traumatic that can be. Probably we've experienced that as patients ourselves. Communication, side effects of medications, loud noises, falls and nightmares, IV, blood, needles, all of these things that are pretty routine for us when we administer care can be experienced as very traumatic for people on the receiving end. ICU in and of itself, and what we know about ICU is research has shown that there's a lot of things that happen, for example, sedation and restraints, intubation, lots of lights and noises, that 80% of people on ventilators experience delirium, which we know delirium is a predictor of PTSD. PTSD is then also associated with trauma. Medical trauma can be suffered in silence. There's a socialization, a conditioning that we've all received around this, that we are socialized to endure medical treatment, to kind of just deal with it. We do a really great job of asking people about the impacts of physical pain. What is it like? Where does it start? What's the duration? What's the experience? Does the medication help? We do a very good job, in my opinion, of managing physical pain. So what we're doing here is talking about how do we then manage the emotional, the psychological, the mental aspects of pain when it comes to trauma. There's many losses that can be related to aging and illness, which may be experienced as traumatic for an individual. And I want to be cautious here. I am not implying that aging in and of itself is a traumatic event, because as we know, there are many older adults that may experience none of these impacts. So I want to just bring awareness to this, that as people get older, if in fact they lose independence, for example, the ability and privilege of driving, if they can no longer dress and bathe and groom themselves and take care of their own shopping and cooking and finances, all of those things that we do when people come to live in our communities. If they've experienced a death of a partner or a spouse, and I put in there, or the decline of someone, meaningful, purposeful roles, health and cognition, and then of course, transitioning into a long-term care setting. All of these may stimulate an experience of trauma. I want to bring attention to, if you think about your interdisciplinary team meetings, your stand-ups, your stand-downs, your care plan meetings, whatever way that you communicate in your community, think about all the times that we talk about residents that have changes in condition. So whether it's how much they eat or drink, cognition, sleep, verbalization, activity, anxiety, all of these things could in fact be tied to trauma. And it doesn't even have to be a current experience of trauma. So what I encourage people to do here is, as we grow in our capacity to understand trauma and trauma-informed care, when you're in these meetings and you're talking about Mrs. Smith who's experienced some kind of change, put into your prompts, asking yourself and one another as a team, might this be related? Could it be a sign of trauma? Behaviors, this is something too, I'm very attuned. The more that I step into trauma-informed care and nonviolent communication, I'm very attuned to the language that we use, that I use, and behaviors is one of those terms. I'm really trying to get us all to move away from using the word behavior as a label, because the definition of behavior is something that we do or say, something that I could hear or see happening. So technically right now I'm having a behavior, I'm speaking, I'm teaching to you. What I prefer instead is the word reaction. And let me explain to you why I'm making that choice and why I'm asking you to consider doing the same. All of these things on this list, and zero doubt that we could make this list much longer. All of these things that residents might do in a care setting can be experienced as staff and by the individual as well as very challenging. So when people yell and argue and they have choices to isolate, withdraw, they resist or decline care, any of these can create a very complicated care scenario, especially when we have staff, remember, because we all have our own trauma histories. So we have all of this going on. So all of these things. Here's what I'd like to, the trauma-informed lens I want to bring to this. All of these things, if you can think of them as coping mechanisms, that at the time when that trauma happened, that these mechanisms, these reactions, if you will, not behaviors, made perfect sense, even though they no longer suit the current circumstance of the person in your community. They made perfect sense at the time and they began as a mode of survival. So I know when I learned that and really integrated that knowledge, it really helped me to bring that trauma-informed lens and have a softening around people when they are doing things or saying things that I may not understand or may not enjoy. If I can think to myself, might this be related to a trauma or a stressful experience in this human being's life? It really helps a whole different perspective come online. The potential impacts of trauma are extensive. Again, so here's several categories: emotional, cognitive, within our relationships, our perceptions about the world and one another, and our physical and mental health. In a little bit, I'll bring up a slide that you can help to integrate that will contain some of these potential impacts of trauma to support you and your team to asking one another, might this be related to trauma? So the idea here is just the extensiveness that when people suffer, remember the definitions in the beginning, trauma can be one event, it can be a series of events, it can be life-threatening feelings of helplessness and hopelessness. So when all of these things come together, it could impact us in all of these areas. So think about all the residents in your community. How many of them might you say or document in their record issues about control, interpreting emotional cues in a way that was not intended, difficulty with memory? So if we can bring that trauma-informed lens to the work would be great. This is a visual that I learned years ago in a training that I took, and I wanted to share it with you. If I am on the ground and I'm looking through this forest and in front of me, I see these individual times of a life, perhaps the resident that I know these things about this individual or one of us, you could put your own words in these bubbles. So as I look up, oh, there's the pandemic. Oh, here's a medical crisis. And you kind of look at each tree individually. What I want us to do is to put that line around them. So if you were to go above the trees and you could float above and you could see the interactivity, how all of these things are connected and correlated, that just because this happened in childhood when I was 8 or 10 or 12, it doesn't mean that the impact of that went away, because what we know, research has borne over and over, is that trauma is cumulative. It's cumulative and impacts us throughout our entire life, no matter how long ago the event occurred. That's just such an enormous principle of trauma-informed care. So everything that happened throughout our lifetime, it builds and builds and builds. And now we have a situation in a nursing home, an emotionally charged, very painful situation. If I were to say to you, this little kiddo, this little one is experiencing some kind of maybe neglect at home, some fighting, conflict with mom and dad, or whatever the parenting structure is. Perhaps there's insecurity about food, or perhaps the little one's pet just died. If that little guy comes to school and he acts out, with those air quotes, acts out, there is not one person in my heart on this call that would not understand that little one and what his body and mind and everything is going through. Of course, it makes perfect sense. What I want to do is bring the same tenderness and care to the adults, to all of us on this call too, if we ever act out. Adults experience trauma throughout a lifetime. We know it's cumulative, and now we have a situation where they have a reaction in a nursing home. To me, this makes so much more sense now. Some nursing homes use trauma-informed practices, but are not using the trauma-informed care lens. And that's all the things that we're talking about here. Practices providing care that ensures safety, trustworthiness, and transparency, and all those other principles of trauma-informed care that I will talk about in subsequent webinars, but they are not considering the role of trauma in those behaviors. So here's how I teach this part. Is I think that if I were to say a group of healthcare professionals, is it your intention to bring care and trustworthiness and transparency and peer support and collaboration and mutuality and all of the principles? Is it our intention? And you say, absolutely. And in fact, I think we do some of those already. I have no doubt that we do. What we're doing here is expanding that to bring that trauma-informed lens. So looking at all of the content in this webinar series and really integrating it into what we think, how we speak, and how we interact with one another and with our residents. So this is the worksheet. And again, you're welcome to take this, blow it up, make it an actual handout. What I envision this is, I encourage people, bring this worksheet into your meeting, stand up, stand down, your care plans, whatever your structures and formats are. So this is a delayed reaction to trauma. This will come out in a book that's being published, we're fingers crossed for later this year. Delayed reaction to trauma. So if you notice, what's going on here is there's multiple categories. So we've got emotional, physical, cognitive, behavioral, and existential. So within each of those categories, there are lists. And again, you could pop these around if it works differently for you, but in generally, when we're talking about emotional reactions, we've got this grouping of symptoms. Physical reactions, we've got another grouping. Now, I want to point your attention to a couple things that increase this to make, I think, a very functional tool. We've got the yes and the no. So if the resident is experiencing any of those in that particular category, you indicate as such. And you'll notice here the source and the purpose for that. If I'm interviewing as part of my trauma screening, will be another webinar, but if I'm interviewing or doing an intake, or I'm in a meeting and we're noticing that there's some kind of change in condition, we might want to ask one another, do we know of, is this resident experiencing any of these potential symptoms? And then the source would be, perhaps it was a CNA, perhaps it was a housekeeper or someone else on our staff. Perhaps it's a family member. So the source is the person who's providing the information. It could be the resident, him or herself. So again, this is one of those tools that I think could really be supportive. Triggers. So triggers are those things, and again, can be absolutely anything. There's no way I could even begin to make a list of these. They are reminders of dangerous or frightening things or people that happened in the past. And I put an asterisk by that because it's important for us to understand. Remember how I just said that trauma is cumulative. So the past can be yesterday. It can be 80 years ago when that person was a child. So that happened in the past. And what's happening is that that person is experiencing that event all over again, even if the current environment is safe. And it's very puzzling for staff because we could be interacting with this person. All of a sudden, they have a reaction that we were not expecting. Maybe they're yelling or pushing at us or cursing at us, or they've completely shut down and dissociated. So it's very puzzling sometimes, and they can come without warning. It can also be puzzling, confusing, frightening, disturbing to the individual, especially if there's no link to the past and or no understanding of why this is happening. It can be very disturbing. Things that we can watch for: stiffness, combativeness, crying out, withdrawal, sudden silence. You can watch for fidgetiness, agitation, perhaps the person's pupils dilate. Maybe they get sweaty, maybe they're twisting a tissue in their hands or rubbing their legs. All of these are clues that if we can help staff understand and look through that trauma-informed lens, it's simply posing a question. Might this person be experiencing? It doesn't necessarily mean that they are, but it might be. So trauma triggers are reminders that can be interpreted as, I'm not safe. I cannot protect myself. I may even die. Now, I've added the last one on this list from my colleague, Scott Jansen. I don't matter. And the reason that's really important, because one of the things is, as human beings, to trust that we matter is core. It is one of our core needs as human beings. And when our ability to trust that we do not matter, that will impact us very strongly. That might even exacerbate our reaction in a particular situation. A couple of questions rather. If you could integrate these into your dialogues with one another, how could this behavior/reaction make sense as a reaction to past trauma? What might this person need to avoid reliving their trauma in the future? So that's where we're talking about, we're bringing that trauma-informed care lens into our dialogues and into our work, into our assessment processes. Long-term care, the impact can be significant for all of us. I know for me, I'm developing a ton of content around the impact of the pandemic on staff. So that's a whole nother topic, but I want to hold both, that these are very complex situations that require increased time, effort, energy, and coordination. So why am I saying that to you here? It's that we are working in a healthcare system that we all know that staffing is critical. It's very challenging right now, and that we are just coming on board with learning about trauma and trauma-informed care and all of these things. That learning process, it takes time. It's not something we can just say, here, staff, read these slides or read this handout, and then magically they integrate it. We are talking about redoing how we think, how we act, how we behave. It takes time and patience and practice and coaching. So we need more emphasis on these concepts in behavioral and mental health. So I'm putting that out there as a request, as a plea sometimes, that this content takes time and attention and diligence to integrate. I want to at least give, at least say, hey, this is the regulation F699, trauma-informed care. This is one sentence, and I want to take a moment to read this. This is what CMS says that the facilities need to do, and this is just the regulation itself. This obviously doesn't include all the guidance to surveyors. The facility must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. I read that and I think, oh my golly, look at all of these things that we are being expected to do. And I agree with all of these things. So there's a lot of work to do. what I want to do is reassure us that we are on a journey together, that we are not going to get this overnight. It is going to take a long time. I love this visual here. This is from SAMHSA, the Substance Abuse Mental Health Services Administration, that they say trauma-informed, creating this type of organization is a fluid, ongoing process. There's no completion date, folks. It's not like we can say, yep, we're trauma-informed now, check box, that we do a screening, check. It's not like that. We are talking about changing everything the way that we do, think, behave, and do with one another. So just a few ideas here. What can you do tomorrow? Actually today, let's say today, because it's early in the morning. What could you do today to begin creating a trauma-informed care organization? I've kind of given you some nuggets throughout this presentation, discussing the impact of trauma, not necessarily the source of the trauma. So I will address that more in detail in the trauma screening presentation. Talking about how that's the delayed reaction to trauma worksheet. How is that event, whatever it was, we may not even know, the person may not know, how does it impact them today in all of those different domains, physical, psychological, cognitive, emotional, behavioral. Talking about those things in all of our clinical meetings, stand-ups, care conferences. Incorporating a trauma-informed lens into all of our facility operations, especially those clinical discussions. And I put those two questions right here. How does this behavior make sense as a reaction to a possible trauma? And what might this person need to avoid reliving their trauma? I want to say one thing here and just clarify quickly. When we say that someone is being triggered or is having a reaction to something, they may or may not be re-traumatized. The way that I try to explain that concept is that even if we're triggered, it doesn't necessarily mean that we'll be re-traumatized. Those are actually two distinct things. If a person is less well functioning once they've been triggered, that would indicate some possibility they've been re-traumatized. But I don't want us to think that if we trigger someone that we've actually re-traumatized them. Those are separate things. And then if I could encourage you to consider integrating the delayed reaction to trauma worksheet that will help support you and your team to identify trauma and really bring on person-centered care. So with that, I will close and just say thanks. Thanks for spending part of your day with me, learning about these topics I'm learning to love. And I'll turn this back over to Nikki to close us out.